Good morning, everyone. Thank you for taking the time to join us for a discussion that I'm incredibly excited to be a very small part of. And thank you to Becker's for the opportunity to share this story. My hope is that everyone will find some value in what we are about to discuss, because I think at times we all struggle with and can relate to the difficulties with the people aspect of change. To get things started, I've been afforded the great honor of introducing a group of gentlemen that I've had the opportunity to work closely with over the past 3 years. Their innovative thinking, leadership in the face of adversity, desire to continually improve care for the patients they serve is inspiring. So your panelists today will be Dr. Matt Angelitis. He is a UC Health ER physician, medical director for UC Health EMS. He is also co-medical director for Colorado Springs Fire and AMR El Paso County, and co-medical director for the Plains to Peaks RETAC in Colorado. And then we have Dr. Stein Bronsky. He is a USACS ED physician at Centura Health. He is co-medical director with Dr. Angelitis for Colorado Springs Fire Department, AMR El Paso County, and medical director for the El Paso and Teller County 911 Authority. And then moving to our Des Moines folks, we have Chief Edgar. He is the board of director for Region 3. He's also on the CAS board of directors and assistant chief of EMS for West Des Moines EMS. And then we have Chief Brian Helland. He's the operations chief for City of Clive Fire Department in Iowa and vice president of the Central Iowa EMS Directors Association. So today the panel is going to be discussing a topic that is very near and dear to my heart, and something that, as I touched on in my intro, many organizations struggle with, and that's change management. We're going to talk about that in the context of building regional systems of care with both community partners and competing health systems, and how streamlined communication is the glue that holds that system together. We know as healthcare providers that communication is vital to the care of the patients we serve. Our panelists in their respective regions have evaluated their existing process, identified opportunities for improvement, and then decided ways to explore which they could create a regional communication standard of care that could benefit the members of their communities. And though I work for Pulsara, this isn't a Pulsara story. This is their story, the Des Moines story, the Colorado Springs story, and how a large group of patient care providers and leaders from EMS agencies, fire departments, and hospitals came together to create something better for the people they serve. While these four were instrumental change agents in their communities and their regions, this was truly a group effort. There were many people involved in building what they've accomplished. So the topics we will cover today is the need for something better. So they identified the need for something better. How did they do that? How did they get started with initiating change? The challenges they faced and how they overcame resistance. And then lastly, the value they realized and how they successfully reinforced the change to achieve sustainability. So without further ado, I'd like to turn it over to the Colorado Springs region. I'll start with Matt Angelitis, Dr. Matt Angelitis, to introduce the Colorado Springs region to you all.
Great, thank you, Kate. I have had the privilege of living in a number of healthcare systems and cities across our country, and I'm thrilled to tell you a little bit about Colorado Springs, which I call home. We are a large urban city, medium urban city, roughly 750,000 members across 2 counties. Next slide. That consists of 3 healthcare systems, Centura Health, University of Colorado Health, and the Children's Hospital System. And we roughly account for 40 plus EMS and fire agencies. That entails roughly 7 hospitals that receive EMS traffic. Our large level 1 trauma center is Memorial Hospital Central. We have a level 2 trauma center, Penrose Hospital, 2 level 3 trauma centers, Memorial Hospital North and St. Francis Medical Center. We have the level 2 Children's Hospital of Colorado Springs. And then we have 2 critical access rural healthcare facilities, Grandview Hospital and Pikes Peak Regional Hospital. As I mentioned previously, roughly 750,000 to 1 million citizens that we serve across the 2 counties and the urban environment.
Great. Thank you, Matt. And Chief Edgar, if you would like to introduce the Des Moines region.
Yes, so the Des Moines region, very similar to Colorado Springs, except we don't have the mountains. The counties involved with our healthcare systems, in our central Iowa region, we have probably about 4 or 5 different counties, and they're fairly small in Iowa that are part of the regional system. So there's 3 health systems here, one being Unity Point Health, that's a multi-state system, the other being Mercy One health system, which is, again, a multi-state organization. And then we do have a VA hospital, and we also have a Broadlawns, the county hospital system. We are also in the range of 700,000 people for the metropolitan area here. With that, we have 40 plus EMS agencies that provide service to the area. So when you look at our actual hospitals, the Blank Children's Hospital is part of the Unity Point Health System. We have Broadlawns Medical Center, which is the county hospital. We have Mercy One Des Moines, which is a tertiary care center that is downtown Des Moines, and Mercy One West Des Moines, which is a suburban hospital. Iowa Methodist, which again is the mothership for Unity Point Health and is located downtown. And then Iowa Lutheran and Methodist West are also part of Unity Point Health. Then we have some outlying rural hospitals that also participate, being Clark County Hospital, Dallas County Hospital, and Davis County Hospital. As I said, the West Des Moines MSA is over 700,000 in population. So as we started our process here, we were very attentive to the Colorado Springs project because there were so many similarities to our 2 regions.
Great. Thank you all for introducing your regions. Now I'd like to move on. So we're going to move into our panel discussion, and starting with the why. I think it's really important for those in the audience to understand how did you determine a need for something like this, to build a regional system of care to enhance your communication. Can you tell us a little bit more about the why? And I'd like to start with Dr. Bronski.
Sure. Thanks, Kate. It was important for us in the Colorado Springs region to understand the amount of errors in communication and the amount of delays that came with the communication status quo. That's something that I think the healthcare system just viewed it almost as a commodity. There were just simply, quote unquote, limitations that nobody could get over. But we saw through Pulsara that we no longer needed to accept the antiquated and fragmented communication system, and therefore we would be able to solve a tremendous amount of the delays and misinformation and miscommunications that existed currently in the past.
Thank you. And Chief Helen, do you have anything to add to that from the Des Moines perspective?
Yeah, thanks, Kate. We had established a committee in the metro area for stroke and STEMI, and that task force had been in place for several years and looked at the transparency of data, and we'll talk more about that a little later. But we identified a lot of the same problems that Dr. Bronski just described, which is the communications piece. We had the hospitals, each health system had a slightly different requirements on how they wanted their time-critical patients to be delivered. And they weren't large differences between the two, but those differences were problematic when we're dealing with over 40 different EMS agencies and over 2,200 EMS providers, because the education piece of that and trying to get everybody on the same page was very difficult in the EMS world.
So moving on to the need for something better. So we talked about the why, established the why. How did the current technology, so you talked a little bit about that, both of you touched on how technology plays a role in fragmented communication. Why is it important to go down that route, pursue that route, versus the methods that people might currently use, like faxes, radios, pagers, those fragmented systems that you had mentioned?
Yeah, I can start here, Kate. So I think we all appreciate that one of the highest risk events in any healthcare or patient care encounter is transitions of care. When we move a patient from one system of care to another, for example, in Colorado Springs with dual response, when our firefighters transition care to AMR, our transporting agency, and then subsequently again when the AMR transporting paramedics transfer care to our healthcare systems. And we had a long tradition of utilizing things like pagers and faxes and radios. And we realized that we frequently missed very important aspects of the patient's care. And so we saw Pulsara as sort of the next leap forward in connecting teams of care for our patients. And so we started looking, like Dave mentioned, at STEMI and stroke care initially, as those very time-sensitive patients require huge teams to deliver all their care needs. And we found that through Pulsara, we could connect all of the players involved in that patient's care on one platform and one patient communication channel.
All right, so this is, I think, a really, really important question, and one that, you know, I've been amazed watching the growth of what you've done in your communities, just because of the various stakeholders that are involved in a project like this. You introduced your regions and mentioned the number of EMS agencies, the number of hospitals. How do you bring such a diverse group of stakeholders to the table, align incentives, and really get people on board with understanding the why and then deciding to take action? Chief Helen, do you mind starting?
Sure. I think that we were very fortunate to already have a group established between the different health systems and with EMS through our Central Iowa EMS Directors Association. And one of the things that helped us out a lot is we had a lot of those people already at the table during regular meetings. And over the years, we had developed some good relationships, and there was some trust between both of the health systems that were involved, and transparency and data sharing. And we knew that we were all there for a common good. And we still recognize that we had those hurdles. And sometimes, as Dr. Angelides mentioned, that it's, you know, the handoff in care is one of the things that is a big stumbling block. Yeah. And so we had some of the stakeholders already there. I think one of the big learning points, and it may come up in a future slide, but one of the big learning points for us in the EMS world was that organizational change is a very slow thing. It's easier for us in the EMS world to make those organizational changes. EMS agencies are typically smaller and more agile than an entire healthcare system. And so we were able to implement the change in the pre-hospital world a little bit easier, and trying to make sure that we found the correct stakeholders within the hospital system was one of our bigger challenges.
Just kind of a follow-up to that question. How did you engage stakeholders? What works, what doesn't work? Chief Edgar, if you'd like to start on this one.
Yeah, so, you know, that was a challenge, and a little bit different, I think, from Colorado Springs. We kind of initiated this process from the EMS standpoint and had to bring the hospitals in. I have a little bit of experience with hospital systems other than EMS, and I think it became pretty evident as we got down to trying to solve all the problems we identified. You know, Pulsara was able to do that, but the people that were at the table at that point were the people that have to do their budgets and stay within their budgets. And we quickly realized that there's a next level of people that make decisions outside of budgets and different things. And we brought them in to our group and explained what was going on. And we also brought some key physicians in that were frustrated with some of the processes. So I think that was a key of getting the right people at the table to be able, that were the real decision makers, because the original people we had in there, you know, they were going to struggle with their budgeting process of getting anything done with that. So that helped on our end.
So something I love that you all have done that. I think is really important is you've created these regional user groups. In Colorado Springs, I know you call it the Regional Communication Committee. I think in Des Moines, you call it your Regional User Group. And you meet at a regular cadence. And I think that's been really important to the success of building this regional communication standard of care. Can you tell us a little bit about how you built those user groups and why and how they've been beneficial?
Sure, I'll start with answering that. As you mentioned, Kate, we do have a committee that we call the Regional Healthcare Communication Committee, and that really birthed out of the Pulsara project because we began to notice very early on that if we didn't have on a regular basis all of the stakeholders from the hospital systems and the service lines and the EMS agencies meeting together, that we were going to try to establish a system that would just be left out there in the open, and it was prone for degradation and falling apart from many different aspects. And so we recognized that the critical importance, and I would say this is one of the absolute staples of our program, is to have that communications committee where all of the stakeholders get together on a regular basis. We're able to discuss any issues that come along in a non-attacking environment. We're all there for the good of the patients and the good of the community. And we discuss what our issues are, what's going well, what's not going well. It also provides a systematic venue for people to bring issues to the table that we can put through our QA and CQI process. And so I can't imagine the continued success of our communications platform and this regional systems of care without that committee.
And Chief Edgar, Chief Helen, have you had similar experience in the Des Moines region with your user group? I know, I believe you meet quarterly and do some additional training and kind of speak about things that are similar to what Dr. Bronski touched on. But if you could tell us a little bit more about what you're doing in Des Moines.
Yeah, so the benefit for us having the groups, we try to meet a couple times a year, sometimes quarterly. It's been difficult the last couple of years to get all the folks there, but same concept. We have all the different areas and users, and I think that has been a platform for us to be able to show what is being done at some systems and what could be done at other systems. But more importantly, all these roles at the hospital seem to change often. So having new people in, kind of cycling them in, they're kind of learning as they go along about the system. And I think having the group there gives credibility to the whole program that, wow, there's a lot of people committed to this. And then we try to pull examples, like if we see something that's working well, have that facility or that EMS agency talk about it. But, there are challenges, and that is the place that we bring out those challenges, and we try to come up with solutions. But very beneficial, and again, I would say that, as was said previously, definitely a necessity to have if you're going to do a regional program.
Yeah, and I'd like to add in on that as well. One of the things we identified through that regional group was that our implementation process in the Des Moines area was very much EMS driven, as David mentioned. And because of that, one of the blind spots we had was that our EMS providers believed that this was an EMS tool that was being driven into the hospital, and they didn't understand what all of the communications occur within the hospital and why this is it's a combined system for both EMS and the hospitals, but the extent to which the hospitals used it, I think there was a real eye opener for a lot of the EMS folks that attended our regional meetings when they started hearing how this was being used within the hospital. And I think there was a lot of aha moments at those meetings when they learned that, the patient channel that I create for that stroke patient is being used by multiple people all the way through this person's, through the stroke alert process and through their care. And so that was a lesson learned, I think, from our standpoint.
Thank you. So data, how important was data to your decision? I know both regions looked at stroke and STEMI. Was there data that you brought forth to these regional user groups to help, kind of set the stage and make the case for something better?
Yeah, so I'll start, Kate. I'm going to use STEMI as an example, but I think many of the same tenets would apply to the stroke service line. We use evidence-based medicine to drive decisions and what we do for patients, and the implementation of Pulsara in our system of care was no different. So when we look at STEMI care in our community, we track all kinds of things for our hospital systems to obtain their accreditation, like door to EKG times or EMS scene time, time to aspirin administration, door to balloon or cath time. And so we were able to take those data metrics that we track regularly within our healthcare systems, and we were able to demonstrate that when we use a patient care channel in Pulsara, we are delivering expedited and more accurate care to those patients. Memorial Hospital Central, our big community hospital, our cardiologists are viewing the EKG in real time with our EMS field providers, and they are controlling the switch to turn on the cardiac cath lab. They are communicating directly with those EMS providers, asking for additional data, more history, additional information. And we found within our community that we really improve the quality of care those patients receive by connecting the entire team that would be involved in that patient's care right up front in real time with our EMS providers in the field. We did the same thing with stroke and door to balloon times, door to TPA times. We're able to track all those metrics and look at how Pulsara impacted the speed with which we deliver care patients need.
Thank you. And so I think, from a change management perspective, it's important to identify champions to help people really see the value and in the why and understand the incentives and what's in it for them. Do you think it's important to have one for each service line in the hospital, for each EMS agency? Kind of how did champions play a role in what you built in your regions?
Well, I'll go ahead and start with that. I think having champions is absolutely paramount. And we learned through our trials and errors that if we did not have good champions, actually, I will rephrase that to say the champions that are decision makers and that can actually feed a mission to the service line or the hospital or the EMS agencies. That is so vital. If we don't have that, then the situation and the implementation just seem to remain in an eddy and not move forward very much. And so we recognized very early on that we needed champions not only in each EMS agency to take responsibility for the agencies, but also high up in the hospital administrations at the very highest level. We had to have a champion. And then that filters down to champions through the different service lines. And that's the only way that we really felt as though we were actually being able to move forward and get to our goal of what we wanted to happen. Moving
on here to something that's really important aspect of change management, and that's socializing the change. You identify the why it's important to change, and then you've got to, gather your group of diverse stakeholders, and then you really got to socialize that change. Do you feel that was valuable, and did you pursue that avenue of socializing change, getting your stakeholders together? allowing them to ask questions and, provide feedback and those types of things. And how important is that socializing change to the success of something like what you've implemented?
I'll jump on that one. So change right now, my perception in healthcare is everybody is so busy that sometimes trying to tackle change or doing something is almost off the table because people are just struggling in healthcare to make things operate. And sometimes it's different to even recognize that something could be so helpful to somebody, and change the way they do things and actually make it more efficient and help you. Yes, the initial change management, there are a lot of people that try to torpedo things when it appears to be more work, and it's difficult. One of the things when we first implemented it that I remember the change management folks from Pulsara coming in and telling us is that things are going to be identified as problems that are going to be associated with the system we're building up, when actually what it is identifying issues that have been there all along that now they're exposed. And I would say that is 100% true, and still proves true today with some of the areas that that we're dealing with. So yeah, all that stuff is very important as far as having the people. We've seen people with champions in certain areas that have far exceeded anything that anybody would have anticipated, and that is good because that pushes other people to do that. And we talked about the 12 lead EKGs. I can remember way back when we first started interpreting 12 leads in the field, and I had some places like, well, how's that going to make a difference in patient care? And we're still going to treat chest pain as chest pain. And now we have people that cardiologists that want the actual connection with the cardiac monitor, so they have the full 12 lead, because they're making complete decisions on calling in teams and decisions about patient care before we ever get to the hospital. And that's pretty impressive from where we came from before we were even doing 12 leads in the field.
I was going to say, I would add, we absolutely used case demonstrations to help our champions in the healthcare systems and EMS systems see the benefit of Pulsara. A common issue with cardiac activations, semi-activations, is at 2 a.m. That involves a whole team waking up, opening some expensive equipment, dirtying a sterile room in the hospital. And Pulsara allows us to limit those false activations. We have real-time connections with the actual interventional cardiologist who's driving that ship. And so we see significant cost reduction and time savings. And we're able to take those cases and show them to the teams and the risk management committees and the quality assurance committees, and get real buy-in from our healthcare systems and EMS partners.
So Chief Edgar, you had touched on resistance to change. There's a number of reasons why people will be resistant to change. And I think, the climate these days, people are overworked and there's burnout and those types of things. And so it becomes even more difficult, in that context. So what are some of the biggest challenges or resistance that you all have faced as you built and created this regional system of care? And then how do you overcome and navigate those? And how do you get people to buy into what your vision is?
Well, just briefly, I think that what we originally developed, the use of a system in Pulsara 4, we still get a little frustrated that about 65-70% of its use on what could, things that were big issues with good times and different things. So just having the different areas that actually put the information in and use it to its full potential are probably some of the frustrations. And then I think some of the other things we've run into from an EMS standpoint is this thought process that, is this making my job easier or making the hospital's job easier? And I've had a couple conversations with different agencies that are looking at Pulsara, and I think they're looking at it wrong. And the reason they're looking at it wrong is this is about patient care. I know that's kind of cliche, but anybody who has a system like this and pays attention, we see it from an EMS standpoint almost immediately when we implemented it, when instead of going to a room and waiting for a nurse, we're going straight to CT on a stroke alert. And for me, I don't think anybody should be looking, even though it'll be easier overall, it really should be about, this is a patient care thing that we all need to do no matter where we are in that team, because if it's your family member, friend, or whatever, you want that to happen rapidly and for good information. So that's probably a couple of the frustrations of just having that understanding that it's not just passing on information.
And I'll add on to that. This is one of my favorite subjects to talk about within this whole system. And so I'll try to condense it. But the resistance to this was monumental in a lot of ways. The resistance came from the hospital side, the emergency department, service lines, EMS agencies. Everybody had an idea of, why do we need to change something? Change is always uncomfortable. And on top of that, what we had to do was tell them to try to project and say, this is what ultimately our goal is for streamlining patient care and decreasing communication errors and delays. But what really happened was that we had to implement Pulsara alongside of the existing systems. So there was a certain amount of time, and for us it was way too long, that the EMS agencies and the hospital systems were doing their normal communication, and then on top of that they were doing Pulsara. And that was to, quote unquote, make sure that Pulsara is working and that we have all the bugs out and we really establish it before we flip that switch and turn off the regular or historical communication processes, which people really liked to hang on to. And so we were actually asking people to double their work. And you talk to a paramedic in the field, they have so much to be doing, and charge nurses have so much to be doing, that you telling them that they were going to duplicate their work was almost a hurdle that we couldn't get over. But we were slowly and steadily able to prove to people and make them understand that this is just temporary and that we are going to end up with this robust system in the end that's going to be much better for everybody. One of the field providers were complaining about, the small screens and them not being able to put in information in the discrete fields, and the charge nurses are complaining about, I can't do everything on a mobile device. I can't keep track of all the ambulances. And really, the resolution for all of this was to very consistently show every stakeholder, being in the field or in the hospital, that we wanted to hear what their complaints were, what their issues were. And then we were able to go back to Pulsara, tell them what our issues were. And Pulsara was extremely responsive to develop workarounds and develop a more robust input system and visual system, so that every one of the issues that was brought up from any stakeholder was very rapidly resolved. And it was all resolved according to their feedback. And once they started to understand that that was the process that was happening, people really started to buy into it.
That's great information. Thank you. So along those lines, did you find that it was easier to, let's say push versus attracting? You can implement change in different ways, but is it best to mandate and say, all right, this is what we're doing as a community. All of our hospital notifications are going to be through technology to the hospital versus the standard radio report? Or do you, attract? Do you communicate with them and allow them to understand really the why and go through that change management process? What works best, and what did you do in your respective region?
I think that in the Des Moines area, I think it was a variety of things. I think we did a little bit of both, and it depends on knowing your audience. Some of the EMS agencies were on board from the beginning, and it was more of a directive of, the push versus the pull. But I think some of the service lines within the hospitals, it was more of having them see the value. I remember sitting in a stroke committee meeting at one of the health systems, and the stroke coordinator and the neurologist, the stroke neurologist that was covering for the day, were both in this meeting when a stroke alert came over. And we had already been in the process of implementing Pulsara, and but it had been implemented for STEMI, but not yet for stroke. And the overhead page and the pagers that went off, there was a 5-minute separation between the stroke coordinator and the stroke neurologist, because that was just one of the communication things. And it was ironic and but kind of funny to be able to say, see, now if you'd had Pulsara, this isn't happening in the STEMI team right now. And it was that one instance was a great case, and it sold the stroke coordinator, or actually the stroke neurologist, on the importance of getting this change made. So I think it varies on who your audience is.
Yeah, I would second those thoughts. I think we initiated with a process that I would consider a little bit of a push, but then almost every service line, EMS agency, and healthcare system that joined the process after that came through the process of attraction. We were demonstrating measurable outcome benefits, and so when our stroke service line sat in quality assurance meetings with our cardiology service line and showed them solutions to problems that they were having through Pulsara, then our cardiovascular service line was like, well, wait a minute, how could we use that? Can you show us that? It works really good for neurology. And then trauma followed suit. And now we have a bevy. We have our mental health, behavioral health teams on board. We have our OBGYN teams on board. We have ICU with cardiac arrest teams. So as the system was demonstrating positive outcomes and improvement in communication, everybody starts to see that and wants to know how they can participate.
Yeah, I like that. The kind of the proof is in the pudding. They're able to see it in real time, how it's benefiting patients in their organizations. Thank you. So, I like to highlight wins. When I'm working with my partners that are implementing change in their regions via Pulsara. So it's important to highlight those benefits. So what are some of the biggest benefits and wins to taking on a project like this? It's not easy. It's very difficult, of course. And you've all been through a lot, but what are the benefits you've realized and wins that you can share with the group?
So I'll start with that. I think that the obvious wins are what was mentioned on the last slide, and Kate, what you said, that the proof is in the pudding. We can show real measurable improvement in patient care metrics across multiple service lines. And that is a huge win. I mean, you just look at that one fact alone, and the whole thing is worth it just for that. And ultimately, our goals were to decrease communication errors, which a lot of people say, oh, there aren't any communication errors. But when you really look into it, there are a tremendous amount of communication errors and tremendous amount of communication delays. And sometimes, unfortunately, those can be traced to bad patient outcomes. Not always, but sometimes. And so one of our huge wins was, as we really got everybody on board, and this became the primary form of communication from the field to the hospitals and largely inside the hospitals up certain service lines, everybody was able to notice right away that the errors in communication and delay in communication just poof, disappeared. And that alone really bought everybody in. And that's where the attraction comes, as was mentioned previously, that other service lines and other EMS agencies are starting to say, oh, how can we get in on this? And then the other win is really connecting the teams. That is one thing that was very, very difficult to get across, not only to the hospital systems, but to the EMS agencies, that although they only see their small portion of this, they will begin to realize as we use the system more robustly that everybody along the designated team is informed and everybody can communicate. Just as Dr. Angelides mentioned earlier about how the interventional cardiologist can actually communicate with the EMS crews. How valuable is that? Just those are small examples that are just huge wins and successes.
Our results that we've had in Des Moines echo what Dr. Bronski just described. It's really a little bit eerie to see how similar the systems are and the experiences that they had, and they implemented their system, prior to what we did in Des Moines, and we're seeing identical results both in patient care. We've got data that shows that we've decreased our door to CT times, we've decreased door to balloon times. And I think David mentioned earlier that we have identified some of those hurdles, people that didn't know we had communications issues, and they were basically identified by using Pulsara.
I don't think that you can do something like this and just set it and forget it, and you've achieved something great, and now we're just going to coast. There's obviously some maintenance and nurturing, continuing to grow and develop your program. So what are you doing to manage and maintain your regional communication systems?
Yeah, so we talked briefly before, Kate, about what we call the Healthcare Communications Committee. But we continue to hold bi-monthly meetings with all the stakeholders where we review the cases, we look at what information is coming through Pulsara and what's missing and how could we improve it. And then we do education through our EMS systems on interfacing with Pulsara and how to use it more efficiently. And then we created a real-time, I'll call it a Google Doc. That's somebody with better IT savvy than me would say it's not that, but essentially a entry point for feedback. So we have the stakeholders all receive emails from EMS crew members, cardiologists, charge nurses, ED providers, you name it. If anybody has an issue with Pulsara, a registrar who's registering patients in the ED, they're able to hop onto a shared web page document and put in their feedback. And we review those every 2 months at our Healthcare Communication Committee meeting. And then we get really good feedback from you guys at Pulsara. We can ask for Pulsara reports about, volumes, numbers, who's using STEMIs, what features in Pulsara are people using, what features should they use. So we get monthly feedback from Pulsara as well, and we take that back to the Healthcare Communication Committee. So it's I don't see that going away. It's an ongoing, ever evolving process.
Yeah, and I would say as Pulsara evolves, there are so many different things to keep people up to date on, good things, because most of them have come from response from what we have seen, in the field on how to improve things. And one example of that is we're getting ready in the Des Moines region to remove phone numbers, because that was one of the biggest things. If we needed to have phone communication with Pulsara calling now, it's all device to device. So we're actually going to remove phone numbers, and we're thinking that will help take care of one of the biggest frustrations. But you have to keep on it. It's a work in progress, and so you always have new people coming in, and but it's an important process to keep on top of it and pass on, so we can continue to improve. I personally look at Pulsara and the regionalized system as important to healthcare as public access defibrillation. And in as far as what it's going to do for and what it is doing for healthcare. And if you don't take the time to look what it is and how it changes healthcare, that's why I'm a huge advocate for this system type of thing, and why I do this type of thing, because I see it as hugely important now and in the future to be able to have this communication.
Yeah, that's great. Thank you. And so the last question before we jump into Q&A, because we have some really great questions from the audience here. Last question I have for you all is, what advice would you give to leadership that might be on this webinar that wants to build a regional system of care? What's the most important advice that you would want to give to them?
So I'll go ahead and jump in on that one. The advice that I would give them is to lay all and identify all of the problems that they have and the issues they have, many of which they don't recognize, and they have to be prompted to understand that they are issues that have room for improvement, and to show them through data and through experience that Pulsara and this type of communication system can resolve most of those issues right out of the gates. I think that's so important for them to see that correlation, and also to understand from a high administrative level that this system really needs to be their ownership. And a lot of times we learned in the past that pushing it through EMS agencies or through one service line was not really the most successful route, but wrapping in the high-level administrators and showing them the value and them understanding that value, then they take ownership of it and can filter it down through the service lines and therefore into the field to create this systems of care. And I think that once people understand that, that has tremendous value.
I would add in patience and persistence. The changes may not come overnight, and you're still going to have a lot of hurdles and things that, as David mentioned earlier, that when we did do the change process, the team from Pulsara came in and identified the fact that there's going to be people that are going to try and torpedo this, and they're looking for reasons for it to fail, and it's easy to blame Pulsara for the failures when in reality the failures were there originally, and Pulsara has the ability to fix them.
All right. Thank you all. So we're going to move on here to Q&A. We have some great questions. Thank you, everybody who submitted a question. The first one is, how would you suggest implementing this program to a city with multiple EMS agencies and hospitals like Seattle, New York City, LA? What's the starting point, if you could give the group a starting point?
Well, I think there's two different starting points. One is hospital initiated starting point out into the field, and then there's kind of how we did it, EMS initiated into the hospital setting. But I guess the first thing you have to do is get a group of, most places, if they're a larger organization, have some form of, I would hope, some form of groups that meet. And if you start doing some research and understanding the benefits, you got to get those change agents that are there and understand. And I would agree with Brian. Leading and doing better is always more difficult than staying the same. And it's so I guess to initiate it, you just need to get your key people. And sometimes, that happens when a system gets stressed too. So, the pandemic and different things, there's a lot of people that have had to move into better communications and management of people because of the pandemic. So look at those opportunities for improvement and get the proper people and groups educated. It took us probably 2 or 3 years to get this established. Now, granted, it was very new at that point, but you got to get people at a table with a common cause first.
I think that in an ideal world, the best way to implement is to get all of the stakeholders, or as many of the stakeholders as you can get together in the same venue, probably using existing venues that are out there, especially in large cities that have multiple hospital systems and God knows how many EMS agencies, and really showing them the common ground value in this, and really inserting that theory and that idea into the greater system, and not think of it as silos, like this hospital system or this hospital system or that EMS agency. And so that's how I would definitely go about implementing it if I were given a clean slate walking into a community.
Kate, one last thing to add on to his response is, we finally took money and costs out of the picture, and we said, if that wasn't in the picture, does this solve a lot of the problems we were trying to deal with for better information? And it was a resounding 100%. Everybody there was yes. Then we worked on the financial issue later, but that can derail you, right away, because people like, that's, as you say, the torpedo, that's an easy torpedo. Well, what's it going to cost, or what's this? And making the decision with the group on the improvement first, and then figuring in our region, it ended up that foundations ended up fronting the money from the hospitals and other things. And within a week, we had the funds to do it once we made that decision that we were going to move forward.
Yeah, I think sometimes it's easier to think of all the why nots when faced with large scale change. It's easier if you're a little bit hesitant and resistant to then just go down the road of why can't I do this, instead of how can we do this. So great points. Thank you all. The next question is from William. Who were some of the champions and the roles? I think going back to one of the previous slides when we talked about the importance of having a champion for service line and for your EMS agencies. Who were some of those people? What were their roles within your organizations?
I think in the city of Colorado Springs, our physician medical directors for our EMS agencies were clearly the folks initially aware of Pulsara and bringing it to the attention of our healthcare systems. And then we early on established service line director champions when Pulsara helped demonstrate to them through some data analysis ROI for implementing this for our stroke and STEMI patients. So service line leaders within the hospitals. And then honestly, we had to get our high level senior administration, like CMO, CEO level folks engaged and on board, and kind of pushing it from the top down, if you will. So we kind of came at it from both angles with champions, but fire chiefs, EMS med directors, service line directors, and then senior administrative folks would be sort of the core group that I would say we kind of worked through and went through to help get it implemented.
All right. It looks like we're coming up on time here. We have time maybe for one more question, and I apologize to the ones we did not get to. We'll reach out to you after the webinar. So how complex is Pulsara? Somebody wants to know of a system. Is it easy to set up and adopt alongside the process of uniting regional healthcare systems, or is there a big learning curve? Was it easy technology to use or difficult?
Easy.
Yes, extreme.
I'm not very technical.
Go ahead, David.
I was just going to say, I'm not very technical, and I would say especially the administrative side of it, it's super simple to use. And most of our folks today, they use their phones for everything anyway. So it's not a huge jump for them to do that. But no, I think it's a very easy system to use.
Yeah, and I would echo that. I would say that as long as the background setup has been taken care of, meaning all the IT solutions, everything that needs to be set up for the success of the program, the actual usage from the hospitals and from EMS is really, really easy. Just to prove a point here, when we launched it in our system, we had multiple EMS agencies that all went live on the same day. And the day that we went live, we recognized that the largest EMS system in our city, which was Colorado Springs Fire Department, hadn't done their training. And we were like 9 o'clock in the morning, we were going live with it. And so we had to push this training out, and it took people about 5 minutes to figure it out. And so we were actually able to go live with it, even with Colorado Springs Fire Department, the day of, without them having any pre-organized training. And that just is one point to show just how easy this is.
Yep.
And if anybody's worried about,
I was going to say, I've personally used it on calls with ride-alongs, and if this old ER doctor can do it, I am very confident our EMS professionals can do it, and they do quite easily.
I was just going to add, as far as the IT stuff, I've never seen IT stuff get signed off on as quick with a hospital system as these did. So if you're worried about all these different hurdles, I can tell you everything is in place for it. That was hospital IT, city IT. It was zero issue on getting that moved forward, and it was quick.
All right. Well, as I said, that was we're going to be our last question there, and the folks that we did not get to, we will reach out to you. Thank you to our panelists so much, and I'll turn it back over to the Beckers folks.
Thank you, Kate, and that concludes our time for today. I want to thank all for an excellent discussion and Pulsara for sponsoring today's webinar.